Hello, my name is Matthias Goertz, and I'm going to share with you some perspectives on COVID-19. To do so, I'll share my screen with you. First, before we start, I'd like you to meditate on the image in front of you. So just sit comfortably, focus on the image, and use it as your meditation object. Just focus your attention on that image and meditate. And now take some deep breath and close your eyes. And open your eyes. It's nice to be able to breathe freely, is it not? So, to get started, myself and a few colleagues in March this year put together a set of COVID-19 scenarios. Scenarios are a useful tool in times of uncertainty to make sense of what's going on. What we did is we determined two major uncertainties at the time. One was the severity of COVID-19, which we felt could range anywhere between moderate to high. And the other one was the effectiveness of the global response, which we felt could range from ineffective to effective. And by using these two uncertainties to frame a scenario frame, we obtained four scenarios, as you can see here. For example, in the Northeast quadrant, a scenario called early spring describes a world in which the severity of COVID-19 has turned out to be moderate and the global response has turned out to be effective. So there would be a world in which, for example, the fatality of COVID-19 might be lower than anticipated, and the global response might have been well coordinated, rational, focused on the right things, and the global economy might have not suffered any significant setback at all. At the bottom left, you have sort of the opposite scenario. We call it the abyss, where basically everything goes badly, and so on. We then defined a few criteria for each of these two axes that we could track, quantitative, qualitative criteria, and actually tracked since March or since April what we saw actually happening in the world. And the result of that tracking up to now has been that we've been moving ever deeper into the scenario we have called fractured world. So we're in a world right now in which COVID-19 has turned out to be rather more moderate in its severity than originally expected, yet the global response has turned out to be rather ineffective. So that's actually quite a paradoxical world in which we find ourselves today. Why am I saying the severity of COVID-19 is trending towards moderate? The most important factor in this is the fatality of the virus, the so-called IFR, or infection fatality ratio, which we've been tracking since late February. As you can see on this chart from left to right, it's been trending down. On the far left, you have the early estimates of different sources, and you can see it's a big range. There were some credible early estimations that already put the IFR below 1%, but there were also some wild guesses that put it quite a bit higher. And I just highlight the one that says 4%, because that became quite famous. You may recall in about early March, I think, there was a report circulated with the title of The Hammer and the Dance. And in this report, someone had modeled the COVID-19 fatalities in the United States and found that within a few months, 10 million or more Americans would die of COVID if the government did nothing. Now, this gentleman made two major mistakes in the modeling. One was the R rate, the reproduction rate that he assumed was higher than you would encounter in a real setting. It was a theoretical value that assumes that every human host is susceptible to the virus at any given time, but that's in reality never the case. So the R value that he plugged into his model to model the speed of the transmission rate was probably quite a bit too high, leading to a very exponential and fast increase of infections. More importantly still, he used a fatality rate that he plugged in of 4%, which he had taken from a report, but this was actually a case fatality ratio and not an infection fatality ratio. A case fatality ratio means what's the number of deaths per registered cases, whereas in IFR is what's the number of deaths per total infections. And in the case of this virus, the number of reported cases and the number of actual infections are very, very far apart. You probably heard of that by now, that there's a big gap between what is registered, and the way you register these cases is by testing positive with a PCR test or similar test. And that number depends on how many people you test, and most people who are infected don't get tested. So that the number of infections is always very much higher than the number of the registered cases. But this gentleman in his model confused the CFR for an IFR and plugged it in and drove the model by the multiplying of the infections times that case fatality rate. And that got you to that incredibly high number of 10 or more million deaths in a matter of a few months. I just want to highlight that because these kinds of modeling exercises are always risky. You can easily get key drivers wrong. So I will show you later some of my own modeling numbers, but I just want to put this up front. Beware of any such numbers and apply your own judgment and see whether you think it's plausible or not. Now, as you can see here on current estimate, my current estimate, the IFR for SARS-CoV-2 is probably somewhere between 0.1 and 0.2% globally. That is in a similar range as pandemic influenza. Pandemic influenza means there's a new strain of influenza that people are not yet used to, they have not been exposed to before, which we have in the last century had about 3 or 4 such events. So every 20, 25 years, you on average, you have a pandemic influenza. And this SARS-CoV-2 IFR is in the same range as those pandemic influenzas, it seems. Just to give you sort of a reference point. Now, the 0.1 to 0.2 estimate is a global average. You may have heard that the severity of the symptoms that people develop is very closely correlated with age. Most severe symptoms leading potentially to fatalities appear in elderly people. And you can see this on the graph I just put up here, where you can see women and men, and you can see the age cohorts. And you can see very clearly up to the age of 50 or so, there are almost no IFR, there's almost no fatalities. And then the fatalities start increasing exponentially with increasing age. Women lag men by about 5 to 10 years, meaning a 70-year-old woman would be as much at risk as a 60-year-old man or a 65-year-old man, which is in line with women living 5 to 10 years longer than men on average. So that it just simply means their immune system is fitter, than the men's at the same age, with a time gap of 5 to 10 years between them. So that's why you see the men having a higher IFR than women. But on average, so the 0.1 to 0.2% for the world, that's an average for the world, across genders, across regions. There will be significant differences across different regions and countries, simply because of demographics. So a country that is relatively useful will have a much lower IFR than a country that has a big elderly population. So if you take, for example, Africa here, I'm showing a very young continent with a median age below 20. I expect that the IFR will be well below 0.1%. In a continent like Europe, on the other hand, where you have a median age of approaching 45, and a pretty large group of people who are above 65, who are especially at risk, you will have an IFR that is 4 or 5 times higher than in Africa. So assuming, at the moment, I'm assuming 0.4% IFR. So you can see that there are big differences regionally, and that's driven by demographics. Also, in addition to the IFR, I've been looking at hospitalizations and other indications of the prevalence of actual disease being defined as severe symptoms. Normally, a disease is defined as something that prevents you from pursuing your ordinary daily routines and affairs. So you really feel sick, and most likely you seek medical attention. So I've used hospitalizations and scaled it up a bit, but because not everybody who requires hospitalization actually gets into the hospital. So I've tried to estimate that. And as you can see, the data, the earliest data was from France. 2.9% of all infected people there had severe symptoms, but it's been also trending down the data. And at current assumption, and based on taking these data as a baseline, it seems that the percentage of those who are severely ill from this infection is about 4 times as high as the percentage who die. So it's 4 times the IFR. So if you take that as a guideline, then the global estimate for the percentage of all people infected who fall seriously ill is somewhere between 0.4 and 0.8. To be conservative, I usually say, well, it's below 1%. That seems to be conservative. So with that, I want to share some key figures just to sort of put things into perspective. Firstly, the percentage of humanity that will be infected with SARS-CoV-2 is 100%, or nearly. There may be some exceptions, but everybody will get infected. This will not be prevented by government measures. Government interventions can slow this process down. They can delay this 100% level, but ultimately they cannot really prevent everybody from being infected. The more severe their measures, the longer it will take, obviously. But eventually it will happen anyways. Also, a vaccine, if it comes, will not really prevent this from happening. It will delay the process, but not stop it. The reason being, my assumption at the moment is that either a natural immunization, having been infected by the virus, or an artificial immunization through vaccine, in both cases, the protection against renewed infection will not last. From all I can see at the moment, from what I read, it's unlikely that it will be a lifelong protection, as it is with a few viruses where you get it once and you never get it again in your life. But this does not appear to be the case with this virus. Instead, it looks more likely that the protection against reinfection may only last a few months or maybe 1 or 2 years, probably not longer, which means even if you've been vaccinated or even if you've been infected, you can reinfect. Yeah. So someone who's taken the vaccine may be protected for a year or two, but eventually the effect of the vaccine wears off. And unless they get regular boosters in regular rhythms, sooner or later there will be a window in which they're not really protected against infection, and the virus will probably in some way or another get to them in most cases. That's why I'm saying you should expect that all of us, all of you, all of us will have this virus. We either already have it or had it already, or we will have it in the next months or years. Now, of those infected, as I just said earlier, only less than 1% are expected to fall seriously ill, which is another way of saying more than 99% of all those who get infected do not fall ill. They either develop no symptoms at all, or they develop mild symptoms similar to the common flu or the common cold or a mild flu. And typically that would not prevent them from pursuing their regular affairs, and they would not typically see medical help. There may be exceptions, some people may do that, but by and large, these people probably should not be considered to be sick. Right? So 99 or more % of all infected people do not fall ill. And finally, as I said at the beginning, the IFR, meaning the percentage of infected people who die, is estimated to be somewhere in the range between 0.1% and 0.2%. Yeah. So these numbers are something to keep in mind. The main takeaway here that's important is, therefore, infection does not equal disease. The 100% of us who will be infected, that number does not equal less than 1% who fall ill. And that distinction is very important for understanding the situation, and it's easily overlooked, as I show you now. On Tuesday, 2nd of October, came news on the BBC that President Trump tested positive. And I rushed to my TV set. I took my mobile phone and took a photo of the screen. So forgive the poor quality of my shot, but I just rushed to capture this headline at the bottom. Test positive for COVID-19. You cannot test positive for COVID-19. You can test positive for SARS-CoV-2, for the virus. You are tested for the virus. It's not a diagnostic that you are ill. You may or may not get ill after having tested positive, right? You may already have some symptoms in some cases by the time you get tested, right? Or you may not, but testing positive for SARS-CoV-2 just means you have been infected. It doesn't mean you will develop a disease. And that distinction, in my view, is regularly not made. To this day, 6-7 months into this affair, people do not understand that getting infected and getting ill in this particular case of this virus are two very different things. So the virus, therefore, is rather moderate in its severity. Why am I saying that the effectiveness of the global response has been ineffective? Now, talking about this hammer that I mentioned earlier, a little cartoon, we have not been hammering on the virus. We have been hammering on ourselves. Our governments have been hammering their citizens for the last 6 or 7 months. They've been hammering their citizens with declaring national emergencies, ubiquitous border closures, curfews in some countries, suspensions of parliaments in some countries, at least temporarily, lockdowns in many countries. A lockdown, remember, means you're basically being locked up without an arrest warrant. That's what it is. Quarantines, similarly. It's a very modern technology dating to the 14th century Venice, yeah, but we still use it. And the whole thing looks a bit like what political theorists call a state of exception. You can read that up. The concept was developed in conjunction with fascism in Europe in the 20s and 30s, just for your information. And that's very much what was done in those days. It's very similar. The list you can compare one to one. Okay. Okay. Now, what's the cost of this hammer? There are a lot of cost to this hammer: psychological cost, societal cost, ethical, trust issues in society. There are all kinds of costs: cost to democracy, cost to rights and liberties, and so on. But there are also some probably quite measurable cost. At least it seems so. First of all, in terms of whether it actually has cost necessary lives. So I looked at the IFRs that were found in studies of early breakouts in Europe, in some parts of Europe. And the IFRs, they ranged typically between 0.6 and 1.0. Now, earlier I said in Europe, based on our estimates, you would expect something around 0.4. And that's probably conservative. I mean, I more likely think it's below that number than above. Yeah? So, but let's say conservatively 0.4%. So you can see that those early IFRs in Europe are clearly higher. Now, that has to be explained. Right? I mean, it just means more people died than would have been predicted just by the inherent nature of this virus. Now, some of that may be explained by a steep learning curve that our health system and our health professionals went through. There are some data that suggests that maybe the fatality rate in ICUs has gone down by 1/3 in some cases, just because better treatment, better methods, better procedures, better decisions being made by doctors. When do you give oxygen? When do you put on intubation? When do you not put on intubation? Doctors have learned a lot in the first few months of this, and mistakes were made. I would call them honest mistakes, unavoidable mistakes, because it was, for many, it was new and came surprising. It came with a vengeance, and in those kind of situations, mistakes will inevitably be made. So I call them honest mistakes, and those mistakes are no longer made now, by and large, because we've gone down that learning curve. But that doesn't explain the entire difference. So there's still, at least in some places, a residual. And I don't have the answer, but I have a question, which is, could it be that especially those national lockdowns that were imposed in many places in Europe early on actually led to higher death rates? Why? Because it created mayhem in the entire system. I mean, all of a sudden, people were told you have to stay at home, and if you were healthcare professionals, now, but did that affect you or not? You then probably became scared because you felt if the government goes to such length, I mean, this is something that outside wartime would never happen. They must know something that we don't know. Maybe the virus is much more dangerous than we thought, and so on. And oh, we need PPE, not enough PPE. Maybe I shouldn't go and see the patient, right? I don't know, right? And I'm not pointing fingers at anyone in the healthcare profession. I'm just pointing fingers at governments who, with their lockdowns, brought everything into a standstill situation. And although the healthcare sector was then told, well, you have to, of course, carry on, I can only imagine the mayhem, at least for a few weeks, that was created by these measures. So I do ask the question, and I do think this needs to be investigated, whether the government interventions killed additional people rather than saving them. Okay, sorry. On the right here, you see GDP. Now that's on everybody's mind. What is the effect of this hammer on our GDP, on our economy? The baseline growth in a typical year for the world would be 3%. I'm arguing that had the global community responded effectively, we would have invested probably far more than we have in those groups that are most at risk, which is primarily, as I said, the elderly, plus of course those who get into hospital. So we would have had massive investment programs into hospital capacities, into equipment, into old folks' homes, into distancing people, giving them more space, having maybe oxygen by the bedside of every single person in old folks' homes and care homes around the world, right, in all countries. I mean, there are a lot of things, obviously getting masks to the elderly and, doing a lot of things to, in a focused way, globally, to protect those actually at risk. And already in February, we knew that it was primarily the elderly who were at risk. I mean, that data came out of Wuhan very, very early on. Right? So it was very well known that there was a risk group and that one should focus on this risk group. But not that much investment was done. I mean, there's a lot of investment now into vaccines, which is good. There's a fair amount of investment into therapies, but I'm uncertain about the amount of investment in the capacities to protect and create an environment for those elderly where they are less likely to be infected. I don't know that we've done that much. Germany passed a budget of, I think, 5 billion euros for hospitals maybe a month or two ago. So 6 months after the thing started. And you can ask, well, why not 6 weeks after the thing started? Why did it take 6 months? So money is invested, but maybe not to the tune it could have been. So my argument is the GDP of 2020, because of the virus, could have been higher than it would have normally been if the global community had not closed borders, had not done national lockdowns, had not done all these quarantine regulations, et cetera, but had instead simply invested in protecting those who need protection. Now, they did not do that. They instead came up, as I showed in the scenarios, as a very ineffective and rather expensive response, which led to our projection for global GDP this year being something like minus 4.5%. So between what it could have been and what it probably will end up being, there is a difference of 8 percentage points of GDP, which is equivalent to nearly $7 trillion US. So our governments have shaved $7 trillion US off our collective well-being. Now, there are other costs, and this is actually maybe even more worrying. What we've seen over the last few months, tracking the scenarios, is increasing global divergence. There was divergence early on. Already in March or so, we observed some countries having what I call a SARS mindset. These were typically countries that had encountered the SARS events in 2003 and who had been able to successfully eliminate that virus. So these countries had a memory of, we successfully eliminated, and we had certain tools such as trace, test, and isolate that worked well in the context of SARS-CoV-1. And naturally, they assumed, since SARS-CoV-2 is so named, that it might react similarly to the earlier one, and that the same approaches might be effective. And so they initially had a mindset that they could do, if they did the right things, they could eliminate the virus. Other countries that maybe did not have the SARS experience, because remember SARS only went to a few countries, mostly in Asia. Those countries that didn't have a SARS experience, maybe they had what I call an influenza mindset. Influenza moves very differently from SARS. Influenza moves in very speedy, very steep and spiky waves. For a variety of reasons that have to do with the characteristics of the virus. So influenza is something that moves so fast, it's not easy to, you can't react to it easily because it's just too quick. It moves through the population within a matter of weeks or months and affects a lot of people. But those people with that mindset, they look more at this hammer and dance idea, or what was called flattening the curve. So the idea there was, well, you can't stop the virus, but you can at least ensure that you cap the sort of the maximum of those waves so that it's not higher than the capacity in your healthcare system, so that you at least avoid people not getting proper care who need it just because the healthcare system is completely overwhelmed, right? Which is a rational and plausible objective, right? If you believe in this influenza image of steep waves. And as I said earlier, the guy who did that modeling in the Hammer and Dance article did have a curve that looked more like a influenza curve, actually. So we had that mindset, and so these two set of countries had rather different initial strategies. But then in June or so, we felt for a while they were converging. The SARS mindset countries realized they couldn't eliminate, and they changed the language from eliminate to control. And the influenza mindset countries did something similar. They, after the hammer having shown to be rather expensive, they looked for means to control the virus without using the hammer. And they, for example, adopted things like trace, test, and isolate, which the SARS countries were already doing, and things like wearing masks and so on. So there seemed to be some convergence in the global community, but that didn't last long. And soon enough, we saw increasing divergence again, and that's what we see to this day. Now, I've tried to just put different countries into 4 buckets, just to give you sort of a flavor of this divergence. And don't take that too seriously. These are just rough and ready buckets. You can argue about any country where they belong, but it's quite mute. It just gives you sort of a conceptual overview. So the first bucket is I call normal. There's only one country, as far as I know, or one country for which I have data, let's put it this way, in that category, and that's Sweden. So Sweden never left the normal. They never, throughout this period they have been in the normal, they did not impose heavy interventions, and instead relied primarily on citizens just behaving reasonably, which the Swedes by and large have done, as we see later. Then there's a bunch of countries, as you can see here, US, India, Brazil, Iran, and probably quite a lot of other countries in those neighborhoods where I don't have the detailed data, but where it looks similar. I call them the back to normal country. These are countries that in the earlier stage did also pull out the hammer in various forms, but they never suppressed the virus all that much. Instead, they did allow the virus to proliferate at a reasonably fast speed. And so when activity went up, they would impose some measures, but not to the degree that it really slowed the virus to a trickle, which means, the infection rates will be relatively high, and therefore they will get through this and back to normal faster, right? And that's why I call them back to normal. Those countries just as quickly as possible want to get back to normal. Let me talk about the one at the bottom first now. I call it the new normal. So not back to normal, but fast forward to a new normal, which is to say countries that sort of embrace this new situation as almost something that is positive. I count into that bucket what I call Confucian Asia, by which I mean Vietnam, Taiwan, the Korea, Singapore, Thailand, and so on. I include here Australia and New Zealand, and with a big question mark, I also include China. China, there's just simply no data available. That's why I put it with a lot of question marks, but I'll revert back to that in a moment. Why is this divergence a problem? Well, there are a few things that could go quite awfully wrong. First of all, of course, there will be a sustained asymmetric immigration and international travel set of regimes. Different countries will be at different stages in the progression of the virus, and therefore will not be easily willing to reopen their borders with each other or to let anybody in from anywhere else. Right? Even though the virus is the same everywhere, but because every country now, because of these different policies, every country now is at a different level. If there were no border closures and no interventions by governments, the virus would have spread much more homogeneously around the world. But because each country closed their borders and then did their own set of policies that differ from their neighbors, the longer this goes on, the harder it gets to reopen borders. There will be a divergence in countries' dependency on the vaccine. So if and when the vaccines come, some countries will be far more desperate for them than others. Some countries by that time may already have reached herd immunity. Others will be very far from herd immunity. And this asymmetry will probably not help in distributing the vaccine. Some governments have staked everything on the vaccine, and they will do almost anything to get their hands on the vaccine. So there's a risk when the vaccines come that it may lead to conflicts and other things. So we all like to see the vaccine, but it could yet make life quite uncomfortable in some ways. We'll talk about that later again. There's a risk here also by countries locking themselves up from the rest of the world, that it encourages diversification of the virus into multiple strains. So imagine the virus is mutating all the time, as viruses are. If, let's say, New Zealand, very proud of having, pull out the heavy hammer and suppress the virus, but of course at the cost of completely locking up the country and virtually letting nobody in and nobody out. Well, you can go out, but you can't get back in. Literally locking up that island from the rest of the world. If you do that for a long period, your local virus that only circulates locally in New Zealand will mutate in ways different than the other virus elsewhere. Right? And this is not, of course, New Zealand alone. I mean, this is just an example that I'm giving. That's any country that locks itself completely off risks that its virus eventually will be different than all the other viruses. So we're at risk. The longer we keep the borders closed, the more we will be at risk of having, a huge bundle of viruses going around, right? And that's problematic because, for example, the vaccines may work for one, but not the other strain, right? So you may end up in New Zealand, for example, have to develop your own vaccine for your own local virus variety. That's an extreme case that may or may not happen, but I think it's not implausible that that could happen. And of course, the longer you keep your countries locked up, the greater that risk becomes. Right? There's a political dimension, of course. There may be distrust among countries, breakdown of the international order and of the mutual checks and balances between countries. We've already seen some of that before COVID appeared, and I think we may see a lot more of that now with COVID. So that's why we are saying that the effectiveness of the global response was ineffective and continues to be ineffective. And I'll talk now about the outlook, and you will see that it could even get worse. Now, in terms of outlook, first I would like to share some numbers. So as I said, I have my own model. It's a rough and ready orders of magnitude model. It's built on top of the key drivers, very simple Excel spreadsheet. It takes the reported COVID-19 fatalities that I just take from Worldometer. So once a month, on the 1st of every month, I update my numbers, and I take whatever Worldometer tells me are these reported fatalities. I then adjust those numbers by looking at surplus mortality. So for some countries, not all, some subset of the countries, I have surplus mortality figures from different sources. I try to keep it updated, but those are not published very regularly. So it's a bit tendential, these data, but where I do have decent data, I'll use it. So for some countries, for some major countries that sort of drive the model, I have an idea what the surplus mortality in 2020 will be. The surplus mortality means in 2020, there are more deaths than on average in the previous 3 or 5 years. So, it's above the baseline that you would have expected, right? And I'm simply assuming that that surplus is entirely due to SARS-CoV-2, right? There may be other reasons why there's a surplus of deaths, but I just can't take those into account, and there's no data on them. So I just make a simple basic assumption that any surplus mortality this year will be due to SARS-CoV-2. So I take that surplus mortality in that country and compare it with the reported fatalities. I get a ratio, and I apply that ratio to the fatalities. So in some countries, that ratio is 1, so no change. So the reported fatalities accurately reflect the surplus mortality. In some countries, that factor is very high. There may be maybe several times more surplus mortality, higher surplus mortality figures than reported COVID figures. So in that case, I scale it up by that factor, okay? And then I take that product of the two things and divide that by the IFR that I discussed earlier. And that gives me the actual, meaning the modeled actual number of infections. As I said, the number of infections that we have to expect is real, is many times higher than the reported infections. The reported infections really just tell you something about the testing strategy in each country, more than about the actual infections. Because the more you test, the more you measure find cases, right? So that reported infection number is quite worthless for my model, right? So I build it up this way. The reported fatalities are a lot closer to the truth than the reported cases. That's why I'm starting from that angle and then adjust it. Okay, so that's the simplicity of the model. So I'm not including China, and there's a reason for that. So Xi Jinping in March went to Wuhan, surveyed the situation there, raised his hand, and ever since his visit in Wuhan, China has not reported any COVID fatalities. 1.4 billion people, 6 months, no fatalities. And I thought, whoa, I've seen this gesture before, déjà vu. Where did I see this before? And then I realized, I saw it here. This is the movie The Matrix. So one of them, there were 3 of them. The hero, Neo, is a human who is able to enter the Matrix. The Matrix is an artificial virtual reality software-built world. He's able to enter into that world, move around in that world, and bend or break the rules of the game in that world, including the physical laws. So he learns to, for example, when people shoot bullets at him, as you see here, he raises his hand and the bullets arrest in midair and fall down to the ground. And that's exactly what Xi Jinping apparently has done. He raised his hand, and since then, no more COVID fatalities in China. And that's why I'm excluding China from my model, because my model is built on reported COVID fatalities. So a country that doesn't report any, it cannot possibly be a good driver for my model. And China, unfortunately, is so big. If I made some wild assumptions about China and plugged them into the model, they would skew the model so much that I would be very uncertain about the total model, right? It would destroy the value of the model because it's just simply such a big country. So I decided to take China out of the model. There are other countries that follow the same communication approach. For example, Thailand followed the lead of China with 2-3 months delay. So for the last few months, Thailand has not reported any COVID fatalities either. But Thailand is a much smaller country. It doesn't really move the needle. I just keep it in the model, extrapolate to Thailand without knowing any better data there. But just because it is smaller and doesn't have a big impact, I leave it in the model, whereas China was just too big to have in the model. So that's why my numbers that I'm going to show you are excluding China. So what's the outlook? What does the model say? Well, according to my estimates, as of 1st of October, we had about 4 million SARS-CoV-2 related deaths and about 1.8 billion SARS-CoV-2 related infected people in the world. These are global figures. The 1.8 billion infected individuals make up just under 30% of the global population, excluding China, as I said. And the IFR so far this year, the average IFR that my model has is 0.22%. I said earlier, I actually believe it's probably, this IFR is probably between 0.1 and 0.2. But because in the early stage, there were those significantly higher IFRs, especially in Europe. And these were real fatalities, right? These people died and they're in this number and I will not take them out of the number. So they skew the IFR to a value that is higher than it probably should be. And that effect, that skewing effect from the early data, that still stays in the model. So I'm trying to sort of dilute that over time. But that's one reason why I'm around 0.2% and not lower. I think that's a reasonably conservative assumption, meaning more likely the IFR is less than this, not more. Meaning more likely the number of fatalities is less, not more. Now for January, I'm taking the current numbers and these are based on whatever real numbers I have. Then I just project in a linear projection out into the future. That's very iffy because of course we don't know how things, patterns will change. The winter's coming, infections in the Northern Hemisphere are likely to go up. Then the springtime comes, they may go down again, etc. I cannot model those things. Also, I cannot anticipate what other measures, governments will come up with. So I'm just on the current trend extrapolating into the future. So that's a very tentative projection. Take it with a grain of salt. But on those current trends, by January we will have just under 6 million fatalities and just under 3 billion infected people. Now, just to give you some markers around these numbers, so the actual deaths in my model are roughly four times higher than the recorded deaths. Maybe 3.8, 3.9 times, but four is just easy to remember. So if Worldometer says as of today 1,050,000 reported deaths, my model has 4 times as much. Right? That's what I believe is closer to the truth, to the actual fatalities related to SARS-CoV-2. As I say, that's a relatively conservative estimate, so hopefully the number is actually somewhat lower than that. The actual infections my model predicts, which are as of today 1.8 billion people, it's about 50 times higher than the reported cases in Worldometer. Now, just a few days ago, the World Health Organization came out with their own estimates. For the first time, they are starting to talk about real numbers, which is good. And they argued that according to their model, there are 760 million infected people, which is about 20 times as much as, or a little more than 20 times as much as officially reported, right? So at least the World Health Organization is now getting into the same order of magnitude than I am. They are saying 20 times, I'm saying 50 times. So that's still a big difference, but at least they are now recognizing there's this huge multiplier that you need to apply to get to the real number, right? I think they're still massively underestimating the number of infected people. As I say, I think it's 1.8 billion, but at least they're recognizing that there's a big factor that needs to be applied. The CDC in the US already 2 months ago said the factor in the US is probably 10. And I think that's probably right, because that also matches my own calculations. So almost 6 million fatalities by the end of this year. That's a big number. Well, let's put that into perspective. In a typical year, nearly 60 million people die globally of all causes taken together, of which about 20% die of complications related to infections. So that's comparable to COVID, right? Which is people dying of complications related to an infection. So 20% of 60 million would be 12 million. So in a typical year, 12 million people around the world. The number is higher in emerging markets and it's lower in developed markets. But on average, for the world, for the global population, about 20% of people die of infections. 100 years ago, it would have been 80% or so. Infections historically were probably the biggest single cause of death. Right? But over the last century, we've been quite successful in developing medicines and treatment and vaccines for infections. So that number has come down. And nowadays, people are more likely to die of cancer and heart disease and those types of things. Right? But still, 20% die of infections. So that's 12 million. Now, 6 million, that's on top, right? So we are sort of adding 50% to the fatalities from infections this year. So that's by no means trivial. That's a big number. But nevertheless, if you think about it, if I told you at the beginning of the year, let's say, I think this year, every year, 60 million people die, you would have said, okay. I mean, the number wouldn't have told you very much. If I had then said, oh no, sorry, I made a mistake. So actually, it's 66 million. You would have said, okay, right. It wouldn't have made any difference to you because the number is very abstract to you anyways, whether it's 60 or 66. Most of you, and including myself, would not have had a prior view anyways, how many people die every year, right? So it wouldn't have made a difference to you. Or if I told you at the beginning of the year, this year, 12 million people will likely die of infectious diseases. And infectious diseases are in principle preventable. They're not always in practice, but in principle preventable, right? You would have said, yeah, okay, it is what it is, right? So the fact that now the whole world is in chaos because of these 6 million fatalities, that's quite fake. That's quite a fake sentiment because normally the world doesn't care. I mean, we have 12 million deaths from infection every year. Nobody, I wouldn't say nobody, of course there are people who do care, but by and large, the population at large, they don't even know and they don't care. So I think if we're honest, we should say we actually don't care. And that's a little bit schizophrenic, right? To go through, to destroy our whole way of life for a number of deaths that is high, but absolutely nothing unusual. It happens every year that people die of infectious diseases in great numbers. And if you have a heavy influenza season, even a seasonal influenza, or you have one of those pandemic influenzas, it will always be a few million more. And normally people don't really pay attention to that, right? So there is something really weird about this current situation. Now, the other thing I want to point out, if my numbers are correct, for January, 1st of January, the world, minus China, will have reached 46% penetration of infection rate of the virus. Now, there's some scientific evidence, early evidence, that the level of new infections per day might plateau at a penetration of 40 to 45%. So it goes up and up and up and up until it reaches about 40 to 45% penetration, and then it stays flat for a while, and then when we reach herd immunity, it sort of drops off. That's sort of the mental image at the moment. Yet to be proven, but there's some plausibility to it. And so we may be reaching that plateau by 1st of January, meaning we have sort of reached the peak, and it will sort of start some time after that will start dropping off. This is a global figure. As I showed you, there's huge differences between countries because of different policies, and therefore some countries will be very far away from this plateau, and other countries will already have, by this time, already have passed that plateau. But on average, the world will potentially reach a plateau by January 1st. So we're actually progressing in terms of getting through this. And by June, on current trends, the world might have reached herd immunity. Now, herd immunity doesn't mean the virus is gone. It just means that the virus finds it harder and harder to find new new hosts to infect. And because it finds ever fewer hosts to infect, because so many people are already immunized, its infection rate will naturally sort of drop off, not to zero, but just to a much lower level, possibly to a level where it just disappears in the general number of fatalities and no longer really stands out statistically. That's quite possible. And many experts say if you have that level of herd immunity, then we normally consider a pandemic to have ended. Yeah? There's still activity, but it's at a low level, and we no longer consider that an epidemic, right? That's just, of course, a convention, but that's how some people think about herd immunity. Now, will there be herd immunity? That's an open question. Possibly there will never be herd immunity because it so appears that the immunization, if you get infected or if you get a vaccine, by the way, it's probably going to be the same, you may be protected from a reinfection for a while, maybe a few months, maybe a year or two, but not forever. And the current thinking that I'm hearing and reading is most likely this will not protect you forever. There are some viruses where you can only get infected once in your life because your immune system will react such that it will prevent any future attack by that same virus and not even allow that virus to infect you. Right? But that is not likely to be the case with this virus. Rather, after a few months or a couple of years, you could be reinfected. Yeah? So think about it. In order for herd immunity to really take place, the degree of immunity would have to be high and lasting. And that's unlikely the case. So what you will actually see is that some people who were infected early, by the time other people who are infected a few months or a year or two later are being infected, the earlier ones are already no longer immune, right? So while for some people the immunity goes up, for other people it starts already coming down. And it's quite possible that we never reach 60 or 70% in actual fact, right? That may not at all be a problem, by the way, because the other part of the thinking about this immunization at the moment is that while you will not be protected from reinfection for a long period, you will be for a while, but then it will taper off. You may well be, by having been infected once or having been vaccinated once, you may well be protected for good, if you're a bit lucky, from ever catching a serious disease from this, developing serious symptoms from this. Why? Because the immune system, once it's been triggered once, it will keep a memory, typically, of this virus, and it will, so to speak, have the blueprint for the appropriate antibodies that fit to that virus, and it will store that blueprint in its memory and will not lose that memory. So if you had been infected, you have recovered, you have been immunized for a while, and then the immunization level drops off, and you get reinfected, the immune system may not be ready immediately and may not be able to prevent the virus from entering your upper respiratory system and colonizing it. But by the time the virus starts, replicating in your throat or in your nasal cavities, by that time, the body already produces the right antibodies in great numbers, which will prevent that local infection from spreading into the lung. So you may, at worst, you have a cold. Yeah? So you get infected, but you don't get sick because your immune system will not allow it to get any further than here, right? So that's really the difference between, does it protect you from infection, meaning, the level of protection is here, or does it prevent you from the virus getting into your lower respiratory system? So the protection is here. And the one that is really important is this one, right? Because the virus is only dangerous if it gets into your lung. Even if you're not protected against reinfection in the future, that may actually not matter. You'll just have a cold, but you don't need to worry about getting sick from it. That would be quite a plausible scenario, I think. And because of that, herd immunity is still an important concept, because it means if 60 to 70% of the people have been immunized once, they probably never catch any kind of disease from this, right? So it is actually a really important, even if there's reinfection, they will not get sick. And that's really what's important, right? Okay, now, I told you earlier that I have these buckets of countries, and I want to show you how they differ, and this is coming out of my model, how they differ in terms of infection rates and time, estimated time to herd immunity. So Sweden, the normal country, you see the normal, these curves are hand-drawn and they're very conceptual, but they're just meant to roughly show what the development has been. So in Sweden, the curve has been drawn out and flat. Swedes have been very disciplined. They have only reached about 15% penetration by now, and it's moving quite slowly. There may be an uptick now that winter's coming, yeah, so it may go up a bit. But on current predictions, Sweden would need another 70 months, so quite a few years, to get to herd immunity. Now, the back to normal countries, which had sort of early rise in infections, and they pulled out the hammer, but didn't use the hammer too long, released it a bit and allowed the virus to spread reasonably freely, and they reach some next plateau, then they do some more government intervention again, it goes down a little bit, but it always stays at a relatively higher level of activity. Those countries are now already in the range of 20 to 40% penetration, so significantly high penetrations. And by January, some of them will have reached that plateau that I talked about, or even starting to reach herd immunity, such as Iran. Iran may only be 2 months away from herd immunity now. And you can see that these back to normal countries typically only have a few months now to herd immunity if they continue on current trend. So some parts of the world, and these are significant, because remember, they also represent many other countries that I'm not showing here in Latin America, in Africa, and some other places. This is the single biggest chunk in terms of human population, and they're rapidly moving towards herd immunity. The modeling through countries, which I said are basically European countries, have a very different curve because they hammered down on the virus much more strongly. However, now that they've realized the cost of the hammer, they are very reluctant to pull out the hammer again. So we will really have to see how the winter plays out. I mean, the winter activity may be very severe, and some governments will be tempted to pull out the hammer again, but reluctantly. So I call it modeling through because it's a little bit difficult to predict, and politicians don't seem to have a clear view on what they need to do. But these countries generally have very long times to herd immunity. Germany has a very low infection level to this day, and it's still not growing very much, although I anticipate in winter it will be growing faster. And it might take, at current trends, it would take decades for Germany to reach herd immunity. Now, it's even worse, or it's at least similar for the new normal countries. Right? The new normal countries, they not necessarily using full national lockdowns, but using a sophisticated mix of measures, keep pushing the virus down and down and down and suppressing it. And whenever it rears its head a little bit, they will again. So you get these oscillations, right? But the result is overall that the activity is very low, and that therefore the penetration of the population with the infection is very low. In Japan, it's still now 7 months into the thing, it's probably only about 1.5%. So these new normal countries will take very long to herd immunity if they don't have the vaccine. Globally, we are near 30% now, and we'll be at this, hopefully at this plateau level, as I said, in early January. And the world as a whole, as an average, again, this is just an average, is only 9 months away from herd immunity. And if you think about that, the time to the earliest available, widely available, safe vaccine is probably at least 4 to 9 months. Then you can see that the world as a whole, and a big chunk of global countries, including a heavyweight like India, may reach herd immunity even before the vaccine really gets to them, which almost means they are not really very dependent on the vaccine to end the crisis at all. They still benefit from the vaccine because they can give it to those who are really at risk, and significantly reduce their risk of getting ill. So they're still very useful to them, but they don't depend on the vaccine to get through this. They are naturally in the middle of getting through this, right? Whereas some other countries, such as the new normal countries and some of the muddling through countries, without the vaccine, they would still be struggling with this in years and years to come. So the point is huge variety in the outlook for different countries, depending on which bucket you're in. So how about the vaccine, you may ask? Yeah. I see 4 possibilities. So first of all, let's assume that the vaccine does become available in Q1 next year, as many experts are currently anticipating, and it does seem quite plausible given that there are so many different vaccines under development. Now, if governments globally align and agree to administer these vaccines as they become available, remember, they will not all become available at the same time, and it will take time to manufacture, distribute, so that, to get the vaccine to those who need it will take some time. But if the global governments collaborate on getting the vaccine administered to those who really need it, meaning those elderly all over the world, and if they do that very effectively and efficiently, we might be, in fact, by July next year, we might be getting back into early spring. Yeah, meaning the worst is over and the crisis is basically over. Yeah. That's possible. However, there's also other scenarios which are less positive. Number 2, if countries instead insist to vaccinate the entire populations because they want to use the vaccine basically to eliminate the virus or to suppress the virus. So it's a suppression strategy rather than a strategy of protecting the needy. So if governments all over the place insist on doing that, meaning vaccinating their entire populations and not opening their borders and their economies, etc., until everybody in the country has been vaccinated, then it will take a lot longer, right? Because to vaccinate an entire population takes a lot longer than just to vaccinate maybe the 20% or so who say, I feel at risk and I would like to have the vaccine, right? Especially if countries force the population to be vaccinated. I mean, in countries where it's voluntary, most people will not even maybe volunteer to be vaccinated, but won't want the vaccination. But in countries where it is mandatory, either de jure or de facto meaning, oh yeah, we don't force you to vaccinate, but if you are not vaccinated, we don't allow you to travel and we don't allow you to participate in any kind of events. And, so, you can make it so uncomfortable. You can bully people so much if they don't want to be vaccinated that they in the end decide to be vaccinated anyway. So that's a de facto forcing. Right? So the second possibility where many countries decide to do that, to use the vaccine to vaccinate everybody, it will take a lot longer. Right? So by July next summer, we probably will, if that happens, we will not have moved at all. We will still be exactly at the same place where we are right now. That's quite plausible too. It could even get worse. As I said earlier, there may be distribution battles over vaccines. So if the vaccine leads to national or civil conflicts, either conflicts between nations or even conflicts within a nation about, who gets the vaccine first. What's the order of, if only people are allowed to travel who have a vaccine, then, everybody will want to have the vaccine, but how do you decide who gets it first, right? You can potentially have civil unrest over the vaccine, right? If it is so restrictively administered. So in which case we would go even deeper into the fractured world, right? Now, there's the fourth possibility, which is the vaccine does not become available anytime soon. Right? It's possible. It's maybe not the most likely scenario, but it's possible that none of these projects become certified in the end because they just don't meet the minimum standards. Or maybe some vaccines do become certified in some places, but they are not acceptable to the majority of populations or so. Also possible. But it may well be that in those cases that some countries will refuse to go back to normal, waiting for a vaccine that never comes, possibly for years, right? And I already earlier talked about New Zealand as an example. I'm not suggesting necessarily New Zealand will be in this category, but I'm just saying as an example, if a country like New Zealand says, or similar countries, we are going to be, closed off from the rest of the world until the vaccine comes, right? And it may not come for years. Then those countries, you may start having that phenomenon I described earlier, which is the diversification of the viral strands, right? And with all the complications there. There's another phenomenon that we may expect if this happens, which is that the IFR, which I said had been trending down, could go up. Why? Because all of us every day are getting older. And remember, the IFR is very closely correlated with age. So the longer the governments prevent their citizens from exposing themselves to the virus, the greater their risk becomes, because with every day they wait, they become older. Right? I'm 55 at the moment. I don't feel at risk. But if I was not allowed to expose myself to this virus over the next few years, all of a sudden I'm 60 and I'm actually at a higher risk group. Right? Every day my risk goes up incrementally, by small increments, admittedly, right? But it goes up for everybody, right? So what governments would de facto do is they would try to protect the 1% that I earlier said are currently at risk of falling severely ill. They're protecting those 1% by putting all the other 99% at a higher risk. So you do the math about that, whether that makes sense or not. But anyways, that's not an implausible scenario that the longer we wait, we just make it worse. If the vaccine doesn't come. Now, if the vaccine comes and it's administered to people, then they do get this immunization, and then that's fine, right? But if the vaccine doesn't come and governments refuse to go back to normal because of that, and waiting, they may make things a lot worse than it is now. So we could yet, by our own policy decisions, be pushed into the abyss. Now, the alternative view I give to you is we could end the crisis immediately. Of course, the crisis only exists because we called it a crisis, right? I mean, the virus itself doesn't cause a crisis, right? Human beings cause a crisis, right? So in principle, we could, of course, end it any moment through through a speech act, right? Utterance saying the crisis is over. If the World Health Organization tomorrow said, okay, people, we've decided to declare an end to the crisis, they could do that, right? They could do that. But of course, people are now so terrified that they wouldn't believe it, right? But we do have a way to end the crisis in a plausible, practical, believable way, which I will show you in a moment. I won't go through the details of these vaccines and what the problematics are around these vaccines. The vaccines are not straightforward. There are many questions and issues around them. But of course, if we get the vaccines, it will be a good thing. The expected efficacy of vaccines will be at least 50% because many authorities have already said they will not certify a vaccine if it's less than 50%. And it may range, 80% or higher. Most vaccines don't reach 100% efficacy, but they reach, somewhere in that range. So that's quite plausible to anticipate. Now, there's an alternative to vaccines, which exists today, which we could administer like starting tomorrow. And that's simply supplying surgical masks to all the people who feel at risk and want a mask. Surgical masks are highly effective against droplets, which is 50% of all transmissions. They are not quite as effective against aerosols, but they're still fairly effective against aerosols. They only let the smallest ones through if the mask is put on properly. And the smallest ones have the smallest load of virus on them. So even if you're not entirely protected from infecting yourself, the infection may be milder because less virus gets into your throat, which gives your immune system more time to react. And so even if you're an elderly person and your immune system is already compromised, if only small particles come through and small amounts of virus, that it probably increases your chances of not falling severely ill quite a bit. So that's why I'm saying the efficacy may lie anywhere between 70% and maybe above 90% if you consider you may get the virus into your throat, but you may not get it into your lung, which is the key, as I said before. So it's quite possible that the surgical mask, if worn and properly worn, is more effective even than the typical vaccine. Yeah, but at least it's in the same range, right? So we already now, without any vaccines, we have a perfectly, effective, not 100% effective, but high rate of efficacy means to protect the elderly. And we're not systematically doing that because governments are so busy letting everybody wear masks, but not focused on those who actually need it, right? So my argument is that if we were to agree globally to supply, unlimited masks for free at everybody on this planet who feels at risk and wants it, we could stop the crisis immediately, right? It would take a few weeks or maybe months to put up the logistics, get the manufacturing processes running. We do have lots of masks on storage everywhere now because all the countries have loaded up on masks, right? But of course, we would have to raise production rates maybe. We would have to put in place the right logistics and all the distribution and all that stuff. But it may cost 10 billion or 20 billion or 30 billion dollars to do this globally. I don't really care. I mean, we've just shaved off $7 trillion of our global GDP. So I think that's tiny investment with very high effect. So we could, if we wanted to, we could end the crisis immediately. So with that, I want to just end with some reflections of a layperson. Is SARS-CoV-2 just another common cold coronavirus? Yes, I think so. I think we will eventually just think of it as another cold virus. The cold is a phenomenon, viral infection that is caused by up to 200 or so different viruses in all kinds of combinations. So every cold that we get is a little bit different because it's a slightly different mix of viruses that are involved. 4 of these 200 viruses are coronaviruses, and most of the others are rhinoviruses. And the typical average adult gets 2 to 4 colds per year, and children get more. So that's a very common thing. And my prediction is that SARS-CoV-2 will just become another one of them. Right? It will just become part of that cold common cold cocktail. It will probably not raise, in the long run, it will not raise the fatality or the danger associated with colds. Colds can, under certain circumstances, become dangerous. You know, even a cold virus could potentially get into your lung, right? But it's very rare. And I predict that SARS-CoV-2 will be just like that. It will just be part of our common cold cocktail. At least so far from all we see, that's how it seems to behave, actually. So the only thing, so it's per se, in principle, entirely harmless. The only reason at the moment it's not harmless is because a certain percentage of the population, as I said, maybe up to 1%, has immunized immune systems that are not capable of handling this virus at the moment because it's new to them. The difference between this virus and all the other cold viruses or the seasonal influenza viruses is that these people, all of us, have not encountered this virus before. Now, most of us have a very well working immune system, a very powerful immune system that very quickly learns to deal with it and doesn't allow it to penetrate to the lower respiratory tract. But some of us, especially elderly people, just because of age and the immune system's functionality, you know, probably trending down with age, just because of that, they are not able to prevent this new virus quick enough from entering into the lung, and then it becomes dangerous, right? So the only difference between this virus and any other common cold virus, as far as I am concerned as a layperson, is that it's new. And as soon as it's no longer new because we've encountered it before, in other words, we've been either infected or we've been vaccinated once, it's no longer dangerous at all for anybody, just like the other cold viruses. That's what I'm expecting. Is COVID-19 a disease? I'm not sure. I'm not sure this complex of you know, effects that we see in patients deserves its own name. Basically, many people have no effect at all, as I said, no symptomatic. Some people have basically a cold, so they have slight symptoms, which are basically a cold. And then the few unlucky ones, the 1% or so, they have pneumonia. Not all of them, but some of them develop pneumonia, right? If it becomes a severe inflammation of the lung, that's for lay people, that's a pneumonia, right? So basically, there's nothing new about these symptomatics. There may be some details that are different in this virus. So the experts will say, yeah, this virus is a little bit different than others. And I totally buy that and you know, respect that if the experts say that. But for a layperson, for you know, the man on the street, this is just another pneumonia. Right? And I think that's important to keep that in mind, that this is not anything new. And that may mean that we should be a little bit cautious about, you know, naming everything with the scary sounding 4 or 5 letter words like AIDS and SARS and MERS and COVID, right? I don't know why of course, AIDS really is a distinct symptomatic and deserves its own name, but COVID-19, I'm not sure it does, right? It doesn't do anything for me to give it this scary sounding name. It's just, if you get sick, you have a certain probability of developing a pneumonia. And that's dangerous for all people. But that's not new. That's always been the case. Is this a pandemic? I'm not so sure either. The most common definition of pandemic I found is it's a disease that affects a large proportion of any population. As I just said, this disease only affects less than 1% of the population. Only less than 1% of the population actually get a disease. 100% get infected, but only 1% get diseased, right? And a pandemic, by definition, is about a disease and not about an infection, right? So, I mean, we're not talking, the cold is going around the world every year. As I said, we get the cold 2 or 4 times a year. But we don't talk about a pandemic, do we? No, because it's not really a disease. We don't consider a cold really a disease. I mean, there can be a severe cold and you may feel a bit sick, yes, but generally we don't consider a cold a disease. And so we don't consider the cold viruses going around all the time. We don't consider that a pandemic, right? So I don't really see that this case is really different, right? yes, 1% of the world population getting sick, that's 78 million people. That's not trivial, but is that a large proportion of the global population? I wouldn't say so. Now, there's another definition I found which says a pandemic is a disease that affects a large number of people, not a large proportion of the population, but just simply a large number of people. And there you could say, okay, 78 million people who may become sick over the course of several years, though, right? 2 to 3 years probably, until herd immunity is reached everywhere. It's not that big a number, but okay, you could, well, that's a biggish number. The point is just simply this. I don't know on what criteria, and the World Health Organization simply then declares a pandemic, and it triggers apparently all kinds of things in governments, like emergency legislations or such things, right? So that's a little bit to be taken with some caution, right? To just simply declare pandemic. I'm not convinced we are in a pandemic at all. Is SARS-CoV-2 killing people? No. No. The virus does not kill anybody. Again, my layman's understanding is people die because of compromised immune systems. That's the cause of their death. You may say, yeah, but that's triggered by the virus. Yeah, but I think that's a distinction to make, right? Because, and this may again be not politically correct to say, but these are people, by and large, with exceptions, who have a compromised immune system simply because they have gotten older than nature had in store for them, right? Now, we all like to get older today than by nature we would be, but at least we have to acknowledge that there's a cost to that aging. And there's not many costs to that aging, and one of the costs to that aging is that some of us, when we get older, have a compromised immune system. And I'm not sure from an ethical standpoint that you can terrorize those 99% of the population who don't have a compromised immune system just because of that 1% who does. I'm not saying these people don't deserve protection. As I said earlier, I think they deserve a lot more protection. But I don't know that because those people who basically have lived longer than nature had in store should or would want to derail everybody else from having a normal life. So I think there is a distinction here between, is the virus itself fatal? No. Are the immune systems sometimes fatal? Yes. And why? In most cases, because we are becoming ever older. So it's a man-made phenomenon. Okay. I want to add another thing. Since I'm at this, there's another man-made phenomenon, which is that we are destroying the habitats, the natural habitats of many, many types of viruses. There are millions of types of viruses on this planet. As you know, they all have to replicate within a cell, either a plant or animal cell or human cell. And most viruses don't use human cells, they use plant or animal cells. But the more we push away the global biomass of plants, of animals, and reduce and destroy global biomass, whether in the Amazon or many other parts of the world, the more we reduce the natural habitat of those viruses, right? And if we force wild animals, for example, ever more into the corner, and these wild animals are colonized by, let's say they're mammals, they're similar to us, and let's say they're colonized by viruses, there will be ever more cases of these viruses being forced to jump over to humans. We are growing our biomass by having more humans and more body weight per human. So our human biomass is growing all the time, whereas all the other biomass is probably shrinking because of us. Yeah. So we are forcing viruses to eventually come to us. So at the same time where we are getting ever older and therefore less capable of dealing with new viruses, we are increasing the likelihood of new viruses coming to us. So this double effect can only lead to ever more cases of this type, ever more viruses somehow finding their way to us humans. And that phenomenon will be entirely human-made. And that's, I think, the important point I want to make here. Let's not reify the problem and put it all on the virus. The virus only does what's natural to the virus, right? It is us humans and our actions who are making this happen, and it will happen more and more. And the next time a virus jumps over to us, it may not be as harmless as this one. It could be a lot more harmful. I mean, we should count ourselves lucky. This one only attacks one age group. Influenza viruses, for example, are also dangerous for newborn kids, or young kids, right? This one is not. I mean, we can count ourselves quite lucky that it's such a benign virus. It could have been a lot worse, right? And next time, maybe it will be a lot worse, right? So that is, I think, something we need to reflect on. We are intervening with nature in ways that makes it ever more likely that a dangerous virus will reach us, and we will be ever less in a position naturally by our immune system to respond to it. That's the dilemma we are moving into. Okay, do we have to control the spread of the virus? Not really. As I said, what we really have to do is protect those who need protection, right? But not by reducing the spread for everybody else. There are a lot of cost to reducing the spread. And I don't only mean the cost to liberties and rights and economy and so on and so forth. I mean cost to people like me who are already 55, and the longer this takes, the longer I'm being held away from the virus, the more dangerous it becomes for me, right? So no, we don't have, in principle, we don't have to control the spread of the virus. I mean, the only argument, yes, we want to protect our healthcare system, but there have been very few cases where healthcare systems really have been under severe strain. I mean, locally in some locations, yes, but not on a national level, right? So what do you do? Okay, if you have too many patients in one location, you send some of those patients to another location, et cetera, et cetera. Yes, I know for the personnel, that's very, very hard. And it puts a big strain on it. But no, we haven't really had the case where things broke down. And we are unlikely now, given where we are now in the development, we are very unlikely to actually get into that situation. So yes, we need to watch the development of the spread, and sometimes locally some measures may be needed, but in general, no, we don't have to control the spread of the virus. We have to protect those people who need protection. Did the virus precipitate this crisis? No, as I said earlier. Viruses don't precipitate crises. Human beings precipitate crises. Why is there no common cold vaccine? If I'm saying this is just another common cold virus, then that becomes an interesting question, right? And there are two answers to that. One, it's too complicated because, as I said, there are 200 viruses involved in colds. So you develop a vaccine that works with one of them, it doesn't make a difference because the other 199 will still go around. So it's too complicated. And secondly, it's not needed. We never really get sick from colds. So nobody would bother to take the vaccine, right? Now, if I'm right, and this is just another common cold virus, that's interesting, right? Because we have heavily invested into vaccines now, and we may not need that many vaccines. We may want to vaccinate all those needy people, as I said. Maybe that's 20% of the population. Yeah, maybe that's 1 billion people or so, or even a bit more. So that's a lot of doses, but will then people later want to have a second and third and fourth vaccination? Ever less, probably, because by that time the virus will already have become basically no longer dangerous to you. If you've been infected once or vaccinated once, that's probably enough. So the reason there's no common cold vaccine is because it's not profitable to anybody to do this. Now, we may run into a problem if the investors in the current vaccination programs wake up to what I take to be a fact, which is we don't really need that many vaccines. Their value will plummet, and we're already now seeing some lobbying efforts. For example, in India, the Indian, Association of the Manufacturers of these vaccines already lobbying the government to say, but we have to vaccinate everybody and it will take 3 or 4 years. They're already trying to raise their importance and their profile with the government and suggest to the government that everybody has to be vaccinated, which is, as I said, totally not the case. Totally not the case. India will already have herd immunity by the time the vaccine arrives. And I think the vaccine companies are starting to wake up to that, and they are counteracting it. So we run into the risk that not only governments set certain policies, that there even will be lobbying effort to prolong the crisis, just because some people have invested heavily in these vaccinations. Will the vaccine end the pandemic? As I said, we can end the pandemic tomorrow by starting to just hand out surgical masks to the people who need them. But my guess is governments will not do that. So many governments have staked their entire credibility on, oh, we will get you the vaccine, and then everything will be fine. They can't change the narrative now, right? Just like they couldn't change the narrative that this is all very dangerous, even though by now they've probably realized it isn't as dangerous as maybe they thought. But they can't turn back on the narrative, because then people will ask, well, what did you do, right? So all those governments who have been staking their credibility on we'll get the vaccine, and then everything will be fine, they will literally now use the vaccine as a pretext to end the crisis, right? Strictly speaking, we don't need a vaccine to end the crisis. We can end the crisis in other ways, but that's probably what's going to happen. Could things get worse? As I said, yes. In the medium term, if we do the wrong things, things could get worse. And finally, how long will the state of exception prevail? I don't know. It all depends on us and on our governments. And I have a feeling that there are some governments who benefit from having a state of exception prevail, as governments would, because it gives them control and power. Yeah, so we may have a longish state of exception just because it suits some members of our societies at the cost of everybody else. Thank you, and have a good day.